big hello to our colleagues. Hopefully you'll be able to take part in the discussion during the day. It is my pleasure to remind to all those attending and to all those watching it in the recording, just a small highlight video of the fourth webinar. Could you please launch that video? Irina, it is a pleasure to welcome you again. You come here time and time again. There's no way of replacing you. You are a friend, and you're always there for all our webinars. My cordial gratitude from the bottom of my heart for your willingness to be a speaker in our webinars. You're a great expert. You're there again. You're here with us again. The format is quite tough. It's very difficult to build the logical canvas of information representation. So we're doing flashbacks. We're doing highlights of the previous events. So now you have the floor. COVID-19 and atrial fibrillation. Personalized approach when prescribing anticoagulant therapy. So is personalized approach possible? Thank you very much, Andrei. I sincerely thank you for the invitation. It is a great honor for me to participate in EURA webinars. Now, in my presentation title, I asked this question: is personalized approach of anticoagulant therapy possible? In some cases, I asked this question broader to myself. Can you manage a patient with COVID-19 and AF without personalizing the anticoagulation therapy? Well, this combination of diseases is a big issue. Well, I'm supposed to show this disclosure. My presentation is supported by Boehringer Ingelheim, so the bigger trend will be the highlight of my presentation in AF plus COVID. So what is the issue? AF is a frequent disease that is seen in patients with coronavirus. It's basically, it's very difficult to say what came first. On the one hand, AF is in the top 10 of comorbidities of COVID-19. It's ranking 7th. This is the American data. And there are multiple publications, there are multiple contemplations on this topic. Pathophysiological explanations as to why patients with AF tend to contract COVID more often. Well, ACE2 inhibitor, you know this, second type, it's higher expression. It is higher in patients with atrial fibrillation, which is basically used by the cells to get the virus to get into the cells. Basically, AF causes people to fall down to come down with COVID more often, fall ill with COVID. AF can contribute to COVID. Patients with sepsis or ARDS, 1 in 3 or 1 in 4 patients had a recurrence of AF, of pre-existing AF, and in every 10th patient there was a de novo atrial fibrillation. That's a huge number of patients talking about here. AF was a meaningful issue because it was seen in 1/4 of patients that died because of COVID. Additionally, what else do we need to discuss here? It is known that the clinical infection is combined with coagulopathy. I will not stop on that too much because of the time limits. The Eurasia Arithmology Association was talking about this quite a lot. What do we need to remember? This pathogenesis is not completely decoded. It could be the direct cause, the coronavirus infection itself induces these changes. Or this could be immune thrombosis, the so-called immune thrombosis. So AF and COVID, this combination doesn't only come often, it's also a fatal combination. It's a fatal combo that is also coming with thromboembolism. AF per se is associated with pulmonary embolism, with the thromboembolism, with clots. COVID is increasing this even further. One patient, one group of patients with or without AF with COVID, D-dimer was high in patients with AF and COVID. C-reactive protein inflammation, myocardial damage troponin was elevated in patients with AF. So what will it show us? What does it show us? This immunothrombosis, these shifts because of the infection, they are provoking the disorders initially occurring with in an AF patient. This causes the thromboembolic complications to go worse. Patients with roughly the same comorbidities, the same gravity of COVID, but with or without AF, that gives you a significantly different difference in occurrence of atrial thrombotic complications. The CHED2 DS2, well, CHED-VASc score, it basically this index, it didn't give the proper association of the risk with the death risk, and there was no risk with thromboembolic complications. The authors of that article make a very careful conclusion. CHED-VASc is insignificant because COVID heightens the thromboembolic complications risk so high that you don't have to bother with CHED-VASc. It's high without looking at it. Inflammatory shifts, inflammatory issues are very meaningful in forming the prothrombotic status of atrial fibrillation. We remember the levels of CRP, interleukin, the pro-inflammatory or neutrophils V lymphocytes ratio. These markers were associated with left atrial appendage clots, with pulmonary embolism. In our works, we have shown multiple times the impact of genetic polymorphisms in the inflammation system, how they can affect the complications. It was more significant in patients that were not receiving AC, anticoagulation therapy. Yeah, there were differences in TNF-alpha genes polymorphisms, where anticoagulants contributed to, well, basically no anticoagulants, more thrombotic events. Anticoagulants help prevent it. The signal path of interleukin, when there is more soluble interleukin-6 receptor, this is meaningful. Pro-inflammatory infections, pro-inflammatory reactions are spiking up. Well, understanding this, there is a significant risk. There is a significant correlation between COVID, AF, and clotting. So AF alone was enough to contribute to higher risk, but COVID just made matters worse. AF and COVID-19. Patients with AF have a higher risk of contagion. At the same time, the coronavirus infection heightens the risk of AF reoccurrence. It increases the AF recurrence risk. Development of new arrhythmias, myocardial injury, fibrosis, hypoxemia, acute overload, cytokine storm. AF increases the risk of thromboembolic complications in patients with coronavirus infection, heart failure, respiratory failure, and death. COVID-19 increases the basic thromboembolic risk in AF patients. CHED-VASc is a poor predictor for baseline thromboembolic risk in the patients with AF. Summarizing, as a clinical decision for myself when I'm looking at patients with AF and COVID, I make two main conclusions. First of all, it's a thorough atrial fibrillation screening. Arrhythmia detection changes antithrombotic treatment tactics big time. Sometimes it's personalized therapy. I will show it on a clinical case. When diagnosing AF, it's not exactly in line with the guidelines because, well, I believe it might affect the patient's prognosis. If you confirm the AF, efficient anticoagulant therapy must be prescribed to make sure that all the conditions are complied with, less mortality, lower mortality, fewer hospitalizations. Right, thorough screening of AF patients. What was I referring to? Getting back to the topic of our multiple webinars this year alone, Andrei, once again, thank you very much for running these. You have indeed selected the topics. You have indeed given us a platform for the experts to get together, to discuss the issues, to share opinions. So 2 webinars I can recall. One was CMP, the other one was dedicated to CMP, the other one was touching it, but not directly. There are doctors that trust in the atrial cardiomyopathy theory. I also believe this to be true. It's particularly relevant post-COVID. I believe that clinicians will agree with me there. We see a whole number of patients that live through COVID with all kinds of arrhythmias, not always AF, could be other SVTs or SV arrhythmias with higher left ventricle. Fibrosis cannot always be assessed in this routine clinical practice. So we see patients with recovered from COVID, patients with AF, with dysfunction, with supraventricular tachyarrhythmias, but not always diagnosed with AF. I believe that quite recently we've had a patient that came with a cardiometabolic stroke. All these changes, all these observations get us back to this theory. Why is cardiomyopathy happening? Why is there a clot in the left appendage? Let me recite the theory. The main factor, atrial fibrillation, is not there. The old arrhythmogenic therapy that all therapists, cardiologists know about, it's arrhythmia with a loss of atrial systole, disruption of hemodynamics, wall fibrosis, because the tension of the shift is changing. RAAS system gets activated. The fibrosis of the atrial wall worsens the symptoms, and as an outcome, there is a left atrial appendage clot. So AF is just one link in the chain. There is one atrial disease. There are no criteria as to what this disease is, what kind of criteria to diagnose, what is the percentage of fibrosis, what is the systolic strain, what is the size of the LV to detect or to talk about cardiomyopathy. But formally, logical, we understand that there is some disease of the atrium. According to my clinical observations, there are quite a lot of those. And that atrial disease, whatever it is, it causes hemodynamic to change, maybe because of fibrosis, chronic inflammation, because of volemic stress, too much volume. Well, the atrial fibrillation could just be a mask of that atrial cardiomyopathy. Sometimes it can be masked with an SVT can be masking as that. And depending on the atrial cardiomyopathy clinical presentation, there could be either arrhythmical manifestations, AF, or the clots in the left appendage. So how this theory is interesting. There is research based on this theory. The use of this theory in patients, use of anticoagulants in patients with high BPM, high heart rate. We're looking forward to getting these clinical results. Me personally, I fully advocate this theory Just an example, a clinical case, 74-year-old female, February 2021, contracted COVID. Post-COVID, well, quite early, unstable heart pressure, arterial pressure, short episodes of speeding up heartbeat, issues in the area of the heart. She didn't go immediately for medical help. She turned several days on. On echo, you see hypertrophic issues in the myocardium. Ejection fraction is 48%. The left atrium is 49 millimeters. Volume index 34. Pulmonary hypertension. Severe patient. AH is grade 3 uncontrolled arterial hypertension. So we didn't find anything stroke-like. We put in the Holter monitoring. There is supraventricular tachycardia, and there is one issue of AF 5 seconds long. This is it. Well, this really looks like atrial fibrillation. However, the guidelines clearly tell us if we're recording a single channel EKG, we need 30 seconds. 30 seconds for AF for verification of the diagnosis. But nobody really knows what is the risk of a stroke in a patient with 5-second paroxysm. The 30 seconds are to convincingly or to definitively categorize the AF as such. In this patient, we see the extension of the left ventricle. It's larger. There are also criteria that are pointing at atrial CMP, high stroke risk and clinical factors, ectopic ventricular activity. In this patient, I would use this consensus, European Heart Rhythm Association 2019. Frequent supraventricular ectopic activity. Basically, a brief incidence of AF that would not have caused the doctor to prescribe ACs. So basically, this could be a criterion. This kind of frequent supraventricular ectopic activity could be a criterion to prescribe anticoagulants. So this kind of activity can cause atrial fibrillation. It can migrate. It can be the first symptom that the atrium is sick, and the fibrillation will manifest. However, a silent AF is almost undetectable. A crystal trial, crystal AF, was a cryptogenic stroke. 3 years of follow-up after that. The loop registers, loop recorders with Holters or with EKG only in 3%. So we're talking about different technologies and different incidence rates. Maybe our patient had a silent AF that we failed to detect, or maybe not. Maybe it's not true atrial fibrillation. It's just supraventricular activity that is screaming of the sick atrium. In my clinical practice, it's very difficult to clearly say to go with the ACs for such patient or not. But for patients post-COVID, for protocol of AF, we are advocating anticoagulants. It's not just preventative doses. It's in this situation, especially where there is suspicion on Holter monitoring, I give the full-fledged dose of anticoagulants as if the patient had an atrial fibrillation. Well, there was a bit of a poetic digression as a recollection of that webinar. So multiple times, for CMP, I've listened to it multiple times. Dear colleagues, I recommend it for everyone. It's a very important topic. So let me get back on track with my topic. So personalizing anticoagulants in AF and COVID. Well, okay, let's believe that we've confirmed the diagnosis. It causes no doubt. The AF is there. So there was an update of the guidelines. The picture for anticoagulation therapy did not change since February. And if our patient has atrial fibrillation and is down with COVID, but is outpatiently treated, oral anticoagulants can be continued, or assess interdrug interactions. It's for remdesivir mostly. If your patient is on remdesivir, the patient is best switched to low molecular weight heparin when the remdesivir is taken. If it's dexamethasone, it's mandatory to switch the patient to low molecular weight heparin. Well, at home, dexamethasone is not really prescribed. Too often, remdesivir is more often the case. And in this situation, OX must be cancelled, low molecular weight heparin, LMWH, must be prescribed. So when the COVID drug is discontinued, the OX can be resumed in the recommended doses. So I suggest not to limit to that small spreadsheet. Our Liverpool colleagues are updating the COVID-druginteractions.org website. Please hit it, check it once again. Sometimes the antibiotics that you might indicate for patients, the antivirals, they're not really prescribed for COVID, but they're not featured in the paradigm, but they might be on that website. If the patient is not, if the patient is hospitalized and there is paroxysm, in moderate severity, you can switch patient to, you can keep them on OX or switch them to LMWH. If there are issues with drug interactions, if the disease, if COVID is moderate, well, it's possible. If the disease is severe, the European, Russian, American recommendation, American guidelines, you name it, severe cause or severe case of COVID is the direct reason to switch from OX to low molecular weight heparin. Well, therapy for severe COVID is tocilizumab, dexamethasone. It's per se, it's the reason to switch to low molecular weight heparin. Up to 50% of patients with COVID can experience acute kidney injury. And in this case, yeah, that's restoring anticoagulants must be prescribed. Concentration of direct OX in patients with COVID, there is one Italian trial on that. That is spring 2020. Severe patients hospitalized with coronavirus infection, they continued the intake of direct antiviral therapy and the OX. 12 patients, there were data of OX concentration before the hospitalization, the blue bars, and the red bars is just 12 patients, right? And the red ones are post-hospitalization, direct OX, DOAC after hospitalization on COVID. Unacceptable titer increase, unacceptable level increase, going way out of the target range, unacceptably high. Literature analysis shows a number of publications about interleukins, interleukin 6, interleukin 1, TNF-alpha. They can affect the cytochrome activity. They mostly inhibit them. Interleukin 6, particularly, 3A4 is inhibiting that. It's inhibiting that. That metachrome is necessary to metabolize apixaban or rivaroxaban or edoxaban, but we don't have that. Out of the three direct products, only the Bigatran is free of that cytochrome 3A4. It's P3A4. It's not really engaged. So in meaningful elevations of cytokines, so we can see the pharmacokinetics of all exabands. Well, there will be an issue. Also, interdrug interactions, drug interactions, renal function impairment, low molecular weight heparin. This is the way to go. After discharge, yeah, go back to DOAX. If there was an AF and we had to cancel the DOAC, and then we cancel it for any other reason, how do we prescribe the OAC for the patients after discharge? I'm using this algorithm. This is not the last source of truth. This is indirect comparison of direct anticoagulants between themselves. If the stroke happens at the backdrop of intake of drugs, I use the Bigetran 150. Apixaban can be selected in full dose or the Bigetran 110 if there was a issue with bleeding. For bleeding, I'm going for the Bigetran or Apixaban. Cranial hemorrhage, it's definitely the Bigetran because it has an antagonist. 80 plus patients, well, the first drug to spring into my mind will be Apixaban, the Bigetran because of antagonist, chronic heart disease, chronic kidney disease, Apixaban or rivaroxaban in lower dose. Class B renal failure, or the liver failure, the Bigetran or Apixaban. Probe, well, sometimes it's difficult to prescribe this rivaroxaban. Tube feeding or significant swallowing disorders go for rivaroxaban or Apixaban. There is no perfect anticoagulant that can save everyone and harm no one. This is my deep conviction. The personalized approach to choosing anticoagulant for each individual patient can increase the effectiveness and safety of treatment. That's my personal opinion. The Spanish colleagues ask the clinicians to look at the hepatotoxicity of DOACs in COVID-19. COVID-19 is hepatotoxic. Antiviral therapy is causing that. COVID-19 related and antiviral therapy is worsening the hepatic function. Renal function at discharge is also needs to be assessed. Patients with high hemorrhagic risk, high thrombogenicity of COVID-19, I mentioned that we need to choose in effect DOAC, preferably one intended to be taken twice a day because of hemorrhagic risk. And the presence of a specific antagonist can reduce the impact of underutilization of the healthcare system in the context of COVID-19 pandemic. You see the wording here, underuse or underutilization. The patients cannot always come to the hospital in due time because of the pandemic. In some cases, the patients come to us not with calculus cholecystitis, it's much worse. We don't have the time to wait for the DOAC to leave the system. We will need to go for the surgery, maintaining the right, or observing the right requirements, observing the requirements. You see, there were no head-to-head comparisons for the Bigetran or other DOACs, but the Bigetran says better features in terms of it's the only DOAC that was superior to warfarin in reducing the ischemic stroke risk. The experts of Thoracic Doctors Association chest, they're showing that the Bigetran 150 milligrams twice a day is the only pharmaceutical that was superior to warfarin in reducing the ischemic risks. The prevention of stroke, prevention of systemic thromboembolism was reduced. Lower hospitalization risk because of hepatotoxicity at the backdrop of the Bigetran use. This is real-world data. We're interpreting them quite carefully. Especially, there was very limited data for Apixaban, not too many patients on that. You see, the Bigetran looks the more favorable option in issues with liver. No issues with parenchyma. I mean, there are no issues that parenchymal damage of liver can play on can affect the Bigetran concentration. This is the algorithm for choosing the pharmaceutical. If the transaminases, if the liver enzyme are higher than 2x the upper threshold of norm, we're supposed to select the Bigetran. The sound from the speaker is breaking up, unfortunately. So we need for the enzymes to go down and not prescribe DOACs until they go down, and to keep patients on heparin. The bigatran will give some nephroprotection to the patients, unless we use it for patients with acute kidney dysfunction, which we don't. This was a very interesting publication for me. It's a fresh one, a week or 10 days ago. Co-authors Gregor Lip. Gregor Lip, for me, is the expert whose opinion I trust fully. This is yet another result. Various DOACs in clinical practice. Medicare retrospective analysis was involved. Again, rivaroxaban or the bigatran versus apixaban. Potentially reduced number of hemorrhagic complications. For the bigatran, I'm also looking at antagonist. This antagonist is stopping, is getting the hemostasis system very fast to the initial level before the bigatran was used without hypercoagulation. So once again, the introduction of idarucizumab returns the hemostatic system to the state before the start of the bigatran administration without hypercoagulation. So Prexbind antagonist could be, its availability in the bigatran could be the reason to go for it for patients, senior patients with trauma risk, young patients with trauma risk, cholecystic disease. So basically, patients with hernia, with high hemorrhage risk. Well, bleedings, we stop them anyway before therapy. Patients with high stroke risk, thrombolysis can be done quickly, or planned catheter ablation, or some cardiac surgery. Completing my talk, I would like to suggest this. There are no clear-cut mechanisms of personalization of therapy, for DOACs. In my practice, I'm guided by this. If I suspect atrial fibrillation in patients, I will interpret all my doubts in favor of presence of AF. To me, I justify this as the atrial cardiomyopathy theory. Inpatient treatment for severe patients is low molecular weight or unfractioned heparin, which is less frequent. Outpatients with COVID or post-discharge, we get patients back on DOACs. The rules of choice, the rules of choosing are the same as for COVID-free patients. We just need to look at hepatotoxicity, renal function, stability. If the kidneys are unstable, go for the pharmaceutical that is not excreted via kidneys. So high efficiency, high efficacy, safety, minimal hepatotoxicity or none are good points to select this pharmaceutical. Once again, unfortunately, there is no such thing as a perfect DOAC. It simply cannot be one. Thank you, dear colleagues. Thank you for your attention. I'm ready to take your questions. Thank you very much, esteemed Irina. Thank you for the brilliant talk. As always, dear colleagues, who has questions to Irina? Irina, I will ask you a brief question. Indeed, personalization for DOACs, for anticoagulants prevention is very important. There are multiple drugs with multiple efficiency profile, activity profile, although they're all OX. In your clinical practice, for practical doctors, practicing doctors, that short outpatient visit time, it's very difficult to make an informed decision. So now we're talking about digital possibilities, digital technologies coming up. Maybe there could be some applications, some smartphone-based things, algorithm of choice. Maybe that can help doctors play more or less safe in that or another situation. Would that be useful, the use of technology? Valery, I'm deeply convinced that without technology, we will not be able to progress, will not be able to move forward. the experience of our clinic's operation, not just that, other outpatient departments, inpatient departments, colleagues create antithrombotic consultancy centers. They even want to introduce this antithrombotic therapy doctor, antithrombotic, anticoagulant doctor therapy. This therapy is really multidisciplinary. GPs limited time slots for visits. Traumatologists, they don't get to interact with that too much. Sometimes, yeah, traumatologists are more proficient in that than GPs, but still, nonetheless, I believe that one of the clinical departments of our the clinical departments of our chair, we're creating the consultancy center and the decisions making support system in the inpatient department. Unfortunately, we don't have the funds to put together the IT system. So far, it's a 24/7 hotline. There are protocols accepted and implemented that are used as algorithms for action. If there are any questions outside the protocol, so possibly severe bleeding on OAC therapy or thrombocytopenia or some other severe complications, the doctors can call that consultancy center, the hotline, to get advice. If there are any, say, applications, or if there are any ways to incorporate it electronically, key in the patient's data in the dose and you get recommendations, it will be perfect. Yes, indeed. Thank you very much. It's very difficult to make a choice. This personalization is still very, very relevant. Yuri, you seem to have a question. Yes, it's also like, music to my ears. I like this topic. I'm always active in that. I was down with COVID myself. I was looking at various medications, or Taxan from the dexamethasone. This was my choice. What if the person is on warfarin? Say this atrial fibrillation and warfarin, and the COVID infection comes in. We know the thromboembolic risk comes up because of COVID. Do we escalate the dose? For example, the habitual figure was 2, 2, 2.5. Can we bring it up to 3, 3.5 to reduce the COVID-induced thromboembolic complication risk? Yuri, thank you very much for the question. Well, unfortunately, there's simply no data to support any viewpoint. Escalation of warfarin therapy, such need is not described, although there is clinical logic behind it. However, nobody really looked at it. The strategy is this: if the patient is down with COVID, they're switched from warfarin, and we don't get to warfarin if possible. Don't get back to it unless there is rheumatic stenosis or mechanic valve prosthetics. Patients with warfarin, and it's not proven for COVID, there could be some condition for a higher clotting risk for that patient. In that case, I switch to the higher dose range. If the range is 2 to 3, I try to up the dose to get it to 2.5 to 3. Yes, same story in my case. I believe it appropriate. Well, with COVID infection, we simply don't have the data to support it. Yeah, nobody knows. Yeah, this is a super customized, super personalized approach based on common sense. Yeah, managing patients on warfarin without at least weekly on home monitoring, it's impossible. That is true. There is a question. Your microphone is muted, Victoria. You seem to have a question. Yes, now you should be able. Yes. Okay, Irina, thank you very much for the great talk. A question for the post-COVID syndrome. Fulminant myocarditis, myocardial dystrophies. We see that when we're analyzing the deformities. Ventricular rhythm disturbances, torpid extrasystole. What are the time frames for you to extend the therapy, anticoagulation therapy in these patients? Does it affect or does it improve the situation, the myocardial situation? Well, basically, The course of the post-COVID syndrome is easier, is better in patients who are on OX. The COVID syndrome is improving, the post-COVID syndrome. The 30-45 days, I will violate that now if there is no hemorrhagic risk elevated, well, patients without AF. Patients in whom OX are only for that. Well, coronavirus is like venous thrombosis. 90 days is what I advocate. Venous thrombosis and PE, pulmonary embolism, 3 months, okay, 3 months for that syndrome. If, of course, the patient is doing well, the tolerance is well, and there is no elevated hemorrhagic risk. I have not found a publication about the extent of manifestation of post-COVID syndrome. However, there is one publication where the intake of yes, so the anticoagulation outpatiently was not improving the situation, but inpatient department did help. My opinion is 3 months. 3 months.